Well,
Well,
welcome
I give
everyone. Yeah.
I give
Well,
consent to be recorded.
okay,
I'm in
good.
Florida.
Okay. Well, Dr. Goldberg's on the record consenting to recording, and we are starting the 2021 academic year edition of Michigan Liver's Grand Rounds. And just some ground rules. We're in a webinar format, which means that the participants can type questions into the Q&A, and provided there's time at the end, we'll discuss those questions. I will be the one moderating, Elliot Tapper from the University of Michigan, and I am joined by two illustrious combatants. Leading off on this important topic, Dr. Vinay Sundaram, who I have respected for the duration of my liver career, beginning as my transplant hepatology fellow and my attending. And I have watched him rise to the level of a thought leader in this particular field, defining the specific needs, the unmet needs for liver transplantation in patients with acute on chronic liver failure, leveraging databases from both sides of the Atlantic. And we are thrilled that to have someone of his stature join us at 4:30 local time in the morning. And I'm very thankful that he will be leading us off. Then after he gives us his viewpoint on why we ought to provide priority for liver transplantation for people with acute and chronic liver failure, we will hear from Dr. David Goldberg, associate professor at the University of Miami. He is an authority both on the use and abuse of large data, clinical trials in hepatitis C and organ transplantation. And although this is a much more civilized hour, we are also very privileged that he would awake at this hour in the morning for us. So without further ado, Dr. Sundaram.
Okay, thank you, Elliot, for inviting me for this important debate. I will be taking the side of patients with acute on chronic liver failure should receive waitlist priority. My talk will be a little bit longer than that of Dr. Goldberg because in the beginning I'll be providing an overview of ACLF before getting into my argument. These are my disclosures, none of which are relevant to this talk. Acute on chronic liver failure as a concept was initially described by Drs. Rajiv Jalan and Roger Williams. They published it in this journal called Blood Purification, interesting choice of journal, back in 2002. But what they described, word for word here, is an acute deterioration of a pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality at 3 months due to multi-system organ failure. And this graph here nicely illustrates the concept that they had described in the previous slide. On the y-axis is liver function, and you can see there is a decline in this represents a deterioration or decline in liver function. The x-axis is time. And now we have 3 lines here, which I'll go through. The green line represents decompensated cirrhosis. And what you can see is that there is a deterioration in liver function, but it occurs more gradually over time. The red line is acute liver failure, where in this situation, there is no decline in liver function because by definition, the patient would not have underlying liver disease. But then in the setting of an insult such as acetaminophen toxicity or drug-induced liver injury, there is suddenly a severe liver injury leading to a rapid deterioration of liver function. And as many of you know, this can sometimes lead to the need for liver transplantation or even death. Acute on chronic liver failure, which is represented by the blue line here, is kind of a combination of the two. Initially, the patient has decompensated cirrhosis, and so there is a gradual decline in liver function over time. But then in the setting of a precipitant, which is not always identified, this leads to a sudden decline in in liver function, similar to that of acute liver failure. Now, the good news is that since 2002, in general, the hepatology community has come to a consensus that acute on chronic liver failure is a true syndrome, which is different from that of decompensated cirrhosis. The bad news is that, unfortunately, from a global standpoint, there has not been a consensus definition as to how to identify acute on chronic liver failure. I'm not going to go into the different definitions. There are actually many of them. I've just briefly highlighted the three most well-utilized or most often utilized definitions of acute-on-chronic liver failure. This includes the Apostle definition, which was derived from a cohort in Asia, the Naxeld definition, derived from a cohort in North America, and then finally the Easel-Cliff definition, which was derived from a European cohort. Now, among these three definitions, I'm going to spend the rest of this talk discussing the Easel-Cliff criteria, not so much in terms of the pros and cons of using this definition. That goes beyond the scope of this talk, but rather in the setting of transplantation. And that's because that's the definition I've used in my own research. And also that is the definition that has been most robustly represented in the transplant literature. Very briefly, the Easel-Cliff definition was derived from a prospective study, and patients who qualified as having acute-on-chronic liver failure, which I'll also abbreviate as ACLF, must have had any one of the following decompensations: ascites, encephalopathy, variceal bleed, or bacterial infection. You do not need to have more than one, just any one of these decompensations. And then organ failure criteria were pre-specified using the Cliff organ failure scoring system, which was previously validated in the setting of cirrhosis. The Canonic study is the landmark study which ultimately led to the derivation of the Easel-Cliff definition of ACLF. This again was a multi-center prospective study enrolling more than 1,300 patients, of whom 96% did not receive liver transplantation, thereby following the natural history of acute-on-chronic liver failure with regards to mortality. As stated before, organ failures were pre-specified based on the Cliff SOFA score, and ACLF grades were ultimately defined based on the association with organ failure and short-term mortality. The organ failures in the Easel-Cliff definition are categorized as intrahepatic and extrahepatic. Intrahepatic organ failures include liver failure, represented by the bilirubin, and coagulation failure, represented by the INR. Extrahepatic organ failures include renal failure, which is specifically hepatorenal syndrome. Chronic kidney disease does not qualify. Brain failure, manifesting as grade 3 to 4 hepatic encephalopathy. Circulatory failure based either on mean arterial pressure or use of vasopressors. And finally, respiratory failure based on PaO2 to FiO2 ratio, or the need for mechanical ventilation due to respiratory distress. And ultimately, what was found with regards to 28-day mortality was that among patients who developed a single organ failure, it was renal failure which was associated with the highest 28-day mortality at around 18%. Subsequently, if the patient developed 2 organ failures, the 28-day mortality increased further. And then with the development of 3 or more organ failures, 28-day mortality increased substantially, approaching 78%. And based on this data, the ACLF grading system was created. Now, for those of you who are not familiar with ACLF, this grading system can get cumbersome. I wouldn't expect anyone to memorize it. I'm just introducing it for familiarity. ACLF grade 1, which is the most cumbersome definition to memorize, includes the development of a single renal failure, or if there's a non-renal failure, that occurs in combination with either renal insufficiency based on the creatinine or grade 1 to 2 hepatic encephalopathy. ACLF grade 2 and 3, also known as ACLF 2 and 3, are much easier to remember. ACLF 2 is simply 2 organ failures. ACLF 3 is 3 or more organ failures. And with regards to mortality over time, the results were as expected. Both 28-day and 90-day mortality increased with worsening grade of ACLF, and with ACLF 3 in particular, the 28-day and 90-day mortalities again approached 80%. So now let's get into a discussion about waitlist mortality and organ allocation policy. This slide here comes from a study that we published in 2019 utilizing the UNOS database, which allowed for the study of thousands of patients in the setting of ACLF who were either listed or transplanted. What's shown here is the cumulative incidence of either mortality or removal from the waiting list over a 1-year period of time from the point of transplant listing. Patients were categorized according to severity of ACLF, including those without ACLF, grade 1, grade 2, and then grade 3. This was also using competing risks regression with transplantation as the competing event. And what you can see is that with increasing grade of ACLF, there was a greater degree of mortality or waitlist removal. In addition to that, when for patients who developed ACLF3, the gap between that and patients with lower grades of ACLF was substantial, approaching 30% at a 1-year time point, indicating that patients with increasing grade of ACLF had higher waitlist mortality, and that gap again was substantially higher among those with ACLF3. A second important point from this paper is illustrated in this slide. On the y-axis, we again have mortality rate after listing, and on the x-axis, patients are categorized according to the grade of ACLF, no ACLF, grade 1, grade 2, and grade 3. They're then subcategorized according to MELD sodium score, with the black bar being less than 25, the blue bar being...
Oh, the one today that you weren't sure about? I thought it was just...
Could people mute their microphones? The blue bar being a score of 25 to 29, the red bar being a score of 30 to 34, and the orange bar being a score of greater than or equal to 35 from the time of listing. Now let's start by focusing on these two groups of patients with ACLF grade 2 and grade 3. What you can see here is that within these two groups of patients, those who were most likely or had the greatest prevalence of either death or waitlist removal within 28 days of listing were these patients with ACLF grade 2 or grade 3, but who had the lowest MELD sodium scores of less than 25. There's a couple of important points to illustrate. Number one is that based on this data, it appears that the MELD sodium score doesn't fully capture mortality in the setting of grade 2 or grade 3 ACLF, particularly grade 3 ACLF. The second thing to note is that by nature, because these patients have a low MELD sodium score, the majority of their organ failures would be what I would call extra MELD organ failures, meaning outside of what's captured in the MELD score, such as brain failure, circulatory failure, or respiratory failure. Looking at this a bit further, as compared to patients without ACLF or ACLF grade 1, the risk of mortality or waitlist removal was lower among these patients who had baseline MELD sodium scores greater than or equal to 35, as compared to these patients here with lower baseline MELD sodium scores. Even though these patients, not only do they have lower mortality, they also have greater priority on the waiting list. Now, we looked into this a bit further as to whether regional sharing based on a MELD sodium score may help to alleviate this problem. In this publication, we examined the 90-day risk of waitlist mortality among patients who were listed prior to implementation of the regional share 35 rule, and then after implementation of the regional share 35 rule. And what we did see is that it did help. As compared to patients who were listed before implementation of share 35, the subhazard ratio for mortality was significantly lower for patients who were listed after the implementation of this rule. However, if you subcategorize these patients again with grade 3 acute-on-chronic liver failure, but specifically those who have grade 3 ACLF, but with extrahepatic organ failures, which is mentioned includes circulatory failure, respiratory failure, and brain failure predominantly, what we found was that implementation of regional sharing based on a MELD score did not improve the subhazard ratio for mortality. Again, suggesting that the organ failures not captured by the MELD scoring system are not adequately accounted for in terms of waitlist mortality. Finally, I want to review this paper, which was also published from our group using the UNOS database. Here we compare short-term waitlist mortality between patients listed with grade 3 ACLF, that was represented by the red line, and those listed status 1A is represented by the blue line. And what you can see here, again, based on competing risks regression, is that the incidence of waitlist mortality was significantly higher among those patients listed with ACLF grade 3. Now, for those of you who like statistics, this again was a competing risks regression. And so you could argue that patients listed status 1A are prioritized for transplantation, and therefore they're going to experience the competing event of transplant more often. And that's a fair point. So let's look at it a different way. This is absolute mortality starting from day 7 on the wait list. Here are patients listed status 1A, again, beginning at day 7 after listing. And what you can see is that from day 7 to day 21, the waitlist mortality is overall stagnant. Let's superimpose that with patients listed with grade 3 ACLF. And what you can see about the mortality from day 7 to day 21 after listing is that the mortality rises. And you can see a substantial gap in mortality beyond day 7, indicating that patients listed as status 1A are in that phase of recovery, whereas these patients listed with grade 3 ACLF remain at high risk for mortality. Finally, I just wanted to introduce some of the multivariable modeling we did in this paper. And in univariable modeling first, we compared patients listed with grade 3 ACLF to those listed status 1A and found the subhazard ratio to be significantly higher for 14-day mortality. In the multivariable model, we controlled for various categories of MELD sodium score. And even when controlling for a MELD sodium score of greater than 40, the subhazard ratio remains significantly higher between ACLF3 as compared to those listed status 1A. Now, there are important limitations to the UNOS database, which I would like to review, and also discuss as to whether they ultimately affect the conclusions. This includes misclassification and selection bias. Misclassification can occur because not all the data for identification of organ failures is available in the UNOS database. For instance, mechanical ventilation is the surrogate for respiratory failure. And as such, patients who are mechanically ventilated, for instance, for airway protection, may be incorrectly categorized as having respiratory failure. However, for the purpose of waitlist mortality, keep in mind that all the conclusions are made surrounding patients with ACLF3. Misclassification will actually mix the pool of patients with ACLF3 with those patients who have lower grades of ACLF, and therefore the end result is that mortality would be underestimated. Again, how do I know this? It's because if you look back at this initial slide here, it's been consistently shown time and time again that lower grades of ACLF have reduced mortality in the short term compared to patients with ACLF3. So if you misclassify these patients into this pool, you will end up underestimating waitlist mortality. With regards to selection bias, there's certain data not accounted for in the UNOS database, such as frailty, comorbidities, uncontrolled infection, and generalized poor protoplasm, which is kind of what we use to determine if a patient will ultimately make it to listing. What I want to point out with regards to selection bias is that inclusion of such patients would also likely raise waitlist mortality. These patients have been selected out because they wouldn't make it to listing, but if you did include them in the analysis, this would also likely raise the mortality, and therefore the mortality estimates you get from UNOS are underestimated. Now, that said, at this point, I presented a lot of data from the UNOS database and my interpretation of how the limitations affect the conclusions. But you may be saying, well, I still need more substantiation. And I would agree with you. When I normally give this talk, I specifically state that the UNOS database is beautiful about providing a big picture, but if you try to apply the data to individual patient care, the picture gets blurry. So let's look at some additional data. If you recall this slide from before, let's now compare it to a more updated analysis. So on the left, we have data from the UNOS database looking at waitlist mortality over 1 year. On the right, this is data published from the Elliot study group, which was published earlier this year in Journal of Hepatology. This study group was a multi-center study of patients throughout Europe who were listed and then ultimately transplanted. And they had full access to granular data, thereby minimizing the risk of misclassification. And what you can see is the data mirrors what we found in the UNOS study. In particular, increasing grade of ACLF was associated with greater cumulative incidence of mortality. In addition to that, the gap between ACLF3 versus lower grades of ACLF was substantially higher, similar to what we found in the UNOS database. And now you may recall this slide here with regards to the MELD sodium score and estimation of waitlist mortality. I'd like to then provide an updated analysis from my friend Ruben Hernandez, who published a study based on utilization of the VA database, which again has full access to granular data. The data here is displayed as follows. On the x-axis, patients are grouped according to MELD sodium score and then subcategorized according to grade of ACLF. I'd like to focus on the middle group here, which are patients with a MELD sodium score of grade 20 to 29. The white bar is the expected mortality based on this MELD sodium score, in this case, 19.6%. What you can see is that across different ACLF grades, the actual mortality is higher than the expected mortality, but this is especially the case among patients with ACLF3, and you can see that across all the MELD sodium categories. In the case of this group, the actual mortality is greater than 3 times the expected mortality. So at this point, I think I presented some compelling data, but you may be saying to yourselves, well, are we really ready to make such a big leap from MELD sodium-based prioritization to ACLF-based prioritization? Well, interestingly, that's already happening. With regards to policy changes on the international front, in the Spanish Society for Liver Transplantation, their recommendations are that the MELD sodium score does not capture the severity of liver disease among patients with ACLF grade 2 and 3, and therefore regional urgency priority should be granted to these patients. In the United Kingdom, they've officially created and have implemented as of May a policy called the ACLF transplantation tier, where patients who have liver synthetic dysfunction as well as organ failure, particularly ACLF3, can be afforded priority on the transplant list. Now, this is just a summary. You can read the official policy online. Now, let me play devil's advocate for a minute, though. Not that David is the devil, but you know what I mean. There is an argument to be made with regards to why not to offer priority to patients with acute-on-chronic liver failure. But in my opinion, that argument is not with regards to the validity of the UNOS database, because I've provided some corroborating data, nor is it with the fact that patients with ACLF, particularly grade 3 ACLF, may be disadvantaged by the MELD sodium score. However, if you frame the narrative along these points of utility, outcomes beyond survival, and implementation, that's where the argument lies, in my opinion. So with regards to futility, this is again from the UNOS database, and the orange line represents grade 3 ACLF. The post-transplant outcomes at 1 year were relatively good, around 83%. But this is the area where the concerns regarding misclassification and selection bias are far more relevant, because based on those limitations, this is likely an overestimate of post-transplant survival among patients with grade 3 ACLF. That said, the updated analysis from the Elliot study group did indicate that post-transplant survival is good among all grades of ACLF, including ACLF3, around 79%, clearly providing survival benefit. However, unless we clearly know which patients in whom transplant will be futile, providing blanket priority to all patients with ACLF3 could lead to transplantation for patients who ultimately don't benefit. Secondly, are outcomes beyond survival. In this study here, looking at quality of life, this was measured across several domains, and the red represents ACLF versus the blue non-ACLF. The ACLF group was not subdivided according to grade. And according to domains of self-care, participation in ADLs, and development of anxiety and depression, patients transplanted with ACLF ended up scoring worse. In addition to that, healthcare resources are not infinite. And this is some data that we're going to be presenting at one of the transplant sessions at AASLD. But what we see here as a snapshot is that across the metrics of post-transplant length of stay, length of dialysis, rehab, discharge to a rehabilitation center, and 30-day readmission, patients transplanted with ACLF, and particularly ACLF grade 3, did worse with regards to all of these metrics. And finally, implementation. ACLF3 is a heterogeneous condition, and should all patients receive equal priority? I would argue that may not be the case, because those with circulatory and respiratory failure are likely to do worse. In addition, recovery of organ failures prior to transplantation improve outcomes. That's been demonstrated. I didn't include that data here, but we've also demonstrated that. And so therefore, should priority be considered not with the development of grade 3 ACLF, but rather once a patient is within a window to maximize the success of transplant? And if so, how do you define that window? And finally, the big elephant in the room is that there is no consensus definition, at least not in the United States, with regards to how to identify ACLF. So in summary, patients with acute-on-chronic liver failure have greater waitlist mortality than patients with decompensated cirrhosis, and this mortality on the waiting list increases with rising ACLF grade and may potentially even exceed that of acute liver failure. the MELD sodium score does not fully reflect mortality in the setting of ACLF, and these findings have been demonstrated using both public registry and primary source data. So in conclusion, should patients with ACLF, particularly ACLF grade 3, receive waitlist priority? If you're basing that answer on whether or not these patients have high risk of mortality within 90 days of listing, which is the exact metric we have used for the last 20 years, the answer is yes. Thank you for your attention.
Dr. Sundaram, that was terrific. And what will happen now is you'll conclude sharing your screen. Dr. Goldberg, if you could go ahead and get started. And then again, just a reminder to everyone, you can type your questions into the question and answer, and we'll handle those at the conclusion of Dr. Goldberg's talk.
So thank you, Elliot and the Michigan team for inviting me. I think this is the highlight of my career from the perspective of my father, who is a lifelong Michigan fan. And Vinay, thank you for your talk, and also thank you for helping to make some of my points as to why patients with ACLF should not receive priority for liver transplantation. So I do have two relevant disclosures. Although I do believe that ACLF is a real clinical entity, I think a fraction of patients that are categorized as having this actually have acute-on-chronic liver failure, which is a problem. So the overarching arguments against added waitlist priority for patients with ACLF that I'm going to briefly go over are: one, as Dr. Sundaram said, there's no consensus definition. The current definitions of ACLF include patients without liver dysfunction. The current data supporting policy change lacks sufficient scientific rigor and further obscures the definition of ACLF. ACLF waitlist priority would add subjectivity to an objective process, and there are logistical challenges to implementing and enforcing a system of waitlist priority for patients with ACLF. And lastly, it would exacerbate inequities for patients with other comorbidities while compromising the utility of liver transplantation. So as Dr. Sundaram said, there is no consensus definition of ACLF, and that is a problem, because if we say in the US we're going to give priority for ACLF, what are we going to give? And I think until we can actually agree what the definition is, it makes it difficult to say we are going to give priority for this condition. We all agree what hepatopulmonary syndrome is. We all agree what HCC is. But how do we give priority for a condition where we can't even agree what it is? As an example of the potential discordance, we had looked at VA data of 5,500 patients with any type of ACLF, and there was little overlap between EASL and APASL criteria for ACLF. So you look here, we had 5,500 people. There was only overlap in 800 patients. 4,300 of them would have met EASL criteria alone. 600 would have met ACLF. So again, what is ACLF and how do we determine who deserves priority? Secondly, not all patients with ACLF have liver failure, despite the name of the condition being acute-on-chronic liver failure. So again, Dr. Sundaram went through the EASL-CLIF organ failures. Of course, 3 out of 6 of them are not liver specific. And you can actually have ACLF with normal liver function, but a non-liver related complication with AKI unrelated to liver disease. For example, depending on how it's coded and what data, a patient with primary pulmonary disease from COVID-19 pneumonia, or someone with an upper GI bleed from a duodenal ulcer with hypotension and transfusion-related ARDS could technically be qualified if they have cirrhosis as ACLF. So I made a sample example patient here using the EASL-CLIF calculator, a patient with a bilirubin, a creatinine of 3.5, so they have AKI, they're hypotensive on pressors, and they're hypoxic. But their bili is 1, their West Haven grade for HE is 0, and their INR is 1.2. So I would argue this person does not have acute-on-chronic liver failure because their liver is not failing. Their liver function is essentially normal. Yet per the EASL-CLIF criteria, this person would have ACLF grade 3. Point 3, the current data supporting policy change lacks sufficient scientific rigor and further obscures the definition of ACLF. Again, getting back to that data that we looked at with patients in the VA, of 5,000 patients with EASL, among ACLF 3 patients, fewer than half actually had liver failure. So we look here at the data and we see that the patients, the median bilirubin of patients with ACLF actually have an essentially normal bilirubin. is that liver failure. And when we look at within the grades of those with grade 3 ACLF in the VA, a similar database to use by Dr. Hernandez, fewer than half of them actually met the liver failure criteria. And 60% met respiratory. But the question here, and actually it was supposed to be slid over to the left of the brain criteria, but how are we calling people severest form of acute-on-chronic liver failure when 40% of them, or only 40%, have the actual liver failure liver criteria? This is an important point because if we're giving people priority for something, they really should have true liver failure. Now, I'm going to get into some of the other concerns about the waitlist registry data that Dr. Sundaram had brought up. So again, though, it's important to know that when we're looking at UNOS data to define this question, what are the primary goals of UNOS data? So the primary goal of UNOS is to match donors and recipients, to track recipients post-transplant, their outcomes, and to provide data for center and OPO performance reports. Secondarily, it's a registry for research. Now, getting to the key components of ACLF using EASL-CLIF, acutely decompensated cirrhosis, organ failures, and that the EASL-CLIF definition was derived from hospitalized patients. Now, despite what Dr. Sundaram said, I would argue that similarities in outcomes in OPT and UNOS data studies of ACLF and other studies does not mean that OPT and UNOS data are valid to study ACLF. So acute decompensation is one of the criteria for EASL-CLIF ACLF, and it can be ascites, encephalopathy, GI bleed, or bacterial infection. There are no data on GI bleed specifically or bacterial infection in UNOS data, so we can't even evaluate those two acute decompensations. Ascites and encephalopathy are in the database at waitlisting, but there's no data on timing. Has it been present at listing? Has it been there the last month, or has it been there for years? This is an important point because you therefore cannot differentiate a chronic condition versus an acute decompensation. And again, you cannot define one of the criteria for the EASL-CLIF ACLF. Getting to the organ failures, 3 of them are lab-based and they're available at listing in every mailed update. So liver, kidney, coagulation, I'm fine with. Encephalopathy is there, although listing, it's without timing, so you don't know if it's truly an acute decompensation, but we can accept that. Respiration, there is no data on oxygenation in UNOS or the reason for ventilation. So again, that is a problem. And circulation, there's no data for vasopressors in UNOS, so there's no way to actually know if someone is on vasopressors. And hospitalization is important because if you look at the EASL-CLIF definition of ACLF, hospitalization is how it was studied in the initial studies, yet only about 5% of waitlisted patients are hospitalized at the time of listing, yet in studies of ACLF and OPT and data, hospitalization was not a requirement. So I'll give you some examples. So patient has grade 4 hepatic encephalopathy and is intubated for airway protection. Technically speaking, based on these labs, this person does not have ACLF. But if you're using UNOS data where you don't have data on oxygenation, this person would be called ACLF grade 2. In truth, the person does not have ACLF, but UNOS data would say they do. Take it a step further. You have a patient that's listed as an outpatient. They have end-stage renal disease on dialysis and poorly treated HE when they come to clinic because they ran out of their lactulose. Based on OPTN studies, this person would be classified as ACLF grade 3, even though they don't actually have ACLF. So again, it's not just muddying the waters with the lower grades. So what are the implications of using OPTN data for outcomes with ACLF? We don't know if they actually have ACLF. If they have it, we don't know if they're the correct grade. We can't determine if they actually then have higher short-term waitlist mortality than patients with ACLF, and we cannot quantify the magnitude of increased mortality. Now, Dr. Sundaram discussed this and suggested that this would actually underestimate the risk of mortality, but I'd argue it might actually be the opposite. What he described would be non-differential misclassification, where you bias the differences towards the null. But I'd argue that that misclassification is maybe more likely to be differential, whereby the sicker non-ACLF patients with higher mortality are likely to be classified as ACLF. So again, that patient with grade 4 encephalopathy who's intubated for airway protection will be classified as ACLF, even though they don't have it, but that person has a higher mortality than just a grade 4 encephalopathy that's not intubated. Like I said here, the grade 3 versus 4 patient who's intubated for airway protection has a higher mortality than that who's not intubated, but this person gets shifted to the ACLF 2 or 3 group, increasing that mortality and lowering the mortality in the non-ACLF group. So what's the potential implications of this? So again, in the study by Dr. Sundaram, they said that if you look at patients with ACLF and a MELD of greater than 35, those with ACLF 3 had higher waitlist mortality than lower ACLF grades. 4 to 6 organ failures had a hazard ratio of 3. 1 to 3 organ failures had a hazard ratio of 1.4. But what if the ACLF 3 is really an ACLF 1 or 2? So this was a paper we recently published in Liver Transplantation with Dr. Bajaj, where we had looked at what is the potential impact of misclassification. We had talked about misclassifying non-ACLF patients as ACLF, but this could be used the same way as misclassifying an ACLF 1 or 2 patient to ACLF grade 3, where there's differential misclassification, meaning that the sicker ACLF 1 or 2 patient is shifted and looked at as an ACLF 3. So as an example, let's just say there's 20 to 30% misclassification. That hazard ratio of 3 that's reported for the ACLF 3 with 4 to 6 organ failures may actually be as small as 1.5, which is a huge difference. Point 4 is that ACLF waitlist priority would add subjectivity to an objective process. So, I've invoked the final rule of the last several years in a negative light, but here I think I'm going to use it to help my argument. So the final rule was released in 1998 as a guide to develop and revise allocation policies. It was partially used as a reason to switch from child-based allocation to MELD-based allocation because of concerns of using ascites and encephalopathy criteria because of subjectivity. They actually specifically said is criteria for status designations shall contain explicit thresholds for differentiating among patients and shall be expressed to the extent possible through objective and measurable medical criteria. So what about subjectivity? So remember, HE grade 3 to 4 is what defines neurologic or brain organ failure. However, as written in the guidelines from AASLD in 2014 on HE, they specifically say the gold standard is the West Haven criteria. They are subjective tools with limited inter-observer reliability. So is a center more likely to call someone a grade 3 HE if it's going to get them extra priority, therefore adding subjectivity to the process? What about intubation versus BiPAP? Early dialysis initiation. Our center is going to say, well, my patient is doing okay on BiPAP, but if I intubate them, they'll get extra priority. Or if we start dialysis early, they'll get extra priority. Is our practice going to change to get people higher priority, as was done in the pre-MELD process when people would be admitted from home to a liver ICU? And as an example of the problems with using subjectivity is that the Karnofsky score is still in the UNOS database, and it used to be there as a measure of center-specific reports and risk adjustment, but it actually was eliminated because people would try to game it. There were people that were classified as severely impaired when they were transplanted with HCC from home. So again, subjectivity. Point 5, logistical challenges to implementing and enforcing a system of waitlist priority. So the system of MELD exceptions exists with electronic data submission for HCC, the tumor number, tumor size, hepatopulmonary syndrome, PaO2, confirmation of HPS diagnosis. The data are easily entered and are auditable by UNOS, which is very important. What about ACLF? So the acute decompensation. Do you have to have the date it occurred, the certification that it's acute and not a chronic condition? How will we define bacterial infection for one of the decompensations? Do you have to have culture positivity? Organ failures. Do you have to enter the oxygenation data or pressor data? How often will it need to be updated? So if you list someone today and their MELD is 35, they keep that MELD for 35. Well, what about a patient with ACLF? We have to put updates every day, every 48 hours. How long will the exception last? So like I said, you get 1 week with the highest MELD score. If a patient is intubated today and has ACLF and 3 days later is extubated, do they still get the priority, or does it last for a week? And lastly, it would exacerbate inequities for patients with other conditions while compromising utility. So organ allocation policies don't occur in a vacuum. Any change we make for one group has downstream consequences to another. The organ demand will always outstrip the organ supply until we can quickly do 3D printing or animals or things like that. So what about other conditions associated with increased mortality? So we say we're going to give people increased priority with ACLF. Well, then what would Dr. Tapper say about patients with sarcopenia or frailty? Why does ACLF get higher priority, but not those patients who we know have increased risk of mortality on the wait list independent of their MELD score? And again, we have to get to the ethical and statutory imperative to optimizing utilization of a scarce resource. So even if you disagree with everything I've presented thus far about ACLF, Dr. Sundaram, which he showed that patients with ACLF3, per their definition, have lower survival. And he showed this. But again, so we're not sure what they have. They may not have liver failure, but they're going to do worse after transplant. Is that really a responsible use of a scarce resource? So in conclusion, although ACLF is an important clinical entity, currently it should not be used for waitlist priority. We need to determine, are UNOS data valid to define and categorize? Will ACLF prioritization harm other patients? How will exceptions be operationalized and audited? And will there be unintended consequences of increased priority with individual patients or to the entire system? And with that, I'll stop sharing my screen.
Well, thank you very much. I cannot emphasize how awesome this has been. I do have a couple of questions that are set up, but please, if you will, the speakers have been very careful to limit their talks so that there's enough time for conversation. I'm going to start out with a question that was posed from the audience for Dr. Sundaram. For patients with ACLF3 who already have a liver offer, is there a situation in which you would wait to transplant? And I think this gets at about exactly what we are worried about when it comes to patients with ACLF3.
Yeah, that's an important question, and this gets along the area of futility. So certainly, if there is an opportunity to improve one of the organ failures prior to going into transplantation, that's a situation where I might wait. In addition to that, it also depends on the quality of the donor organ. Data indicates that that poor quality donor organs will also influence post-transplant mortality. So I think what needs to be done, and this can only be done prospectively, the UNOS database or even any other retrospective registry probably won't be able to clearly define this, is to kind of look at dynamic changes with regards to organ system failures and whether they are worsening or improving. And if there's that potential, as I mentioned before, of a window where you can improve a certain organ failure, and in particular, respiratory failure is the one that continues to have that signal, not just in UNO studies, but also in Terry Archner's paper from France, I believe. Then you can actually improve post-transplant mortality. So I think it's a factor of two things. Number one is whether you can improve one of the organ failures, and number two is the quality of the organ offered. But to answer that question would actually even require more time, because it's an important question which we really can't get a clear answer on based on the data that we currently have.
Thank you. So I'm going to ask a question of Dr. Goldberg and then open up the floor for more discussion amongst our panelists here. So David, you presented a largely, it's a critics presentation. The problems with misclassification, the issues of bias inherent in the data, and yet today when we round, we will meet that person with grade 4 HE whom you say does not have ACLF3, but we know that these are people who are sick and who are probably disadvantaged by the current organ allocation system. So beyond these issues of misclassification, what do we do for the person who is today sicker than their MELD score?
So I think the challenge, though, and I agree, but the problem is not limited to that patient, because their neighbor who may not have that, who's frail and sarcopenic, also has an increased mortality. So the challenge, though, is that we don't operate in a vacuum, and you have to sort of be equitable in how you do it. So the answer is, let's get more organs. But the problem is that any change, if you make priority to that person, and I don't disagree, But there's unintended consequences, though, that you have to think about. When we started doing HCC priority, what happened? We were transplanting a whole lot of people with HCC over those who actually had no other options, those with decompensated cirrhosis. We've seen now with all the changes that we've actually decreased HCC transplants, which I think has been a good thing. So to that patient, I would say, I agree, you as an individual should get higher priority. But the problem is, and I think as clinicians, we have to sort of separate ourselves from the patient in front of us versus the system. We as transplant physicians are stewards of a scarce resource. So you can't just keep on saying one-offs to this patient, this patient, this patient, because we operate within the system.
You know, one
Some a political non-answer, but you know.
One counter argument I would make, though, is that frailty doesn't occur in a vacuum with ACLF. In fact, you published the paper which showed that patients who have baseline frailty develop ACLF. So the one thing to consider then is, frailty certainly increases mortality. Females may not be properly prioritized based on the MELD sodium score. But again, these things don't occur in a vacuum, and they're not mutually exclusive. So the question is then, at some point, should we create a system which can account for comorbidities not present in the MELD sodium score, which are clearly linked to that hard outcome of waitlist mortality, which again is the best metric, which is the only metric we've been using for the last 20 years. And if you create ACLF as one of those metrics for priority, are you necessarily excluding those patients who are frail, patients who are female, et cetera? So
just 2 points I'd like to raise. So first off, hopefully this will get better thanks to the work of Dr. Kwong and colleagues, who Dr. Kwong signed in from California, which big kudos. But what about the patient's neighbor who's a small female who is disadvantaged by the system, though? Again, the second point, though, gets to the subjectivity, though. So Elliot, you say this other person has ACLF 3, it has HE grade 3, and they have, brain failure. Well, what if your colleague, Dr. Fontana, comes on, you switch service, and he thinks they actually have grade 2 encephalopathy? Do they lose their priority? And this is a problem with subjectivity, and one of the reasons why we got rid of the child score is, how do you objectify something like encephalopathy, which per experts, I'll defer to Elliot, whose K is on this, is somewhat subjective.
So your points about subjectivity are well taken, but I just wanted to, for the listeners, you mentioned Dr. Kwong. And so one, just tell the listeners a little bit about why you brought her work up. And then two, this dovetails very nicely with a question that was raised by Dr. Kulkarni, who we're privileged to have attend this meeting, who asked what we can do to overcome the shortcomings of the current definition. So what kind of data ought we be collecting? What is the process by which we can improve allocation using these concepts?
So I think I brought up Dr. Kwong because they published a great paper in Gastro called MELD 3.0 to try and address one of the disparities in transplantation of women who we use creatinine instead of EGFR, and women on average, due to less body mass, are going to have, or muscle mass, are going to have a lower creatinine for similar stages of renal failure. So they built a new MELD score that includes gender, which would help to improve gender equity, which is very important. In terms of Dr. Kulkarni's question, the challenge, of course, and another disclosure I should have added, is that I don't think waitlist priority should be purely based on 3-month mortality. And that is, again, I think a problem in the system, is that we don't think about post-transplant outcomes at all. So I think that would be one of my things, is that we need to think beyond the wait list, beyond the 90-day mortality. But again, though, if you're going to collect more data, there have to be some sort of objective data that you can collect that can be applied. Could we start collecting, the LFI of people on the wait list? Could we do the number connection test and time? Obviously, these are problems because these are unfunded mandates for people to collect and then audit and things like that. And that's the challenge we face.
Vinay, do you have anything to add to this?
Yes. What can be done to overcome the shortcomings of the current definitions? The problem is that there is some overlap with regards to these shortcomings. So if you look at Easelcliff, Naxeld, and Apazal, all three of them incorporate hepatic encephalopathy to some degree, where, with Easelcliff and Naxeld, it's actually part of the definition to qualify, but also with the Apazal criteria, hepatic encephalopathy may not be a requirement, but it does represent that kind of acute liver decompensation, whether it could be jaundice, coagulopathy, or the development of ascites or hepatic encephalopathy, which again is a subjective criteria. I guess the primary issue that would have to be addressed would be whether we can make objective criteria for the identification of grade 3 and 4 hepatic encephalopathy. I do think that the other extrahepatic organ failures are a little bit better defined, which includes a hard endpoint for MAP or a PaO2-FiO2 ratio, or the need for an intervention due to circulatory or respiratory failure. But I think hepatic encephalopathy is the biggest obstacle. And that's going to be even in the setting of prospective studies, because if you're using West Haven criteria, again, you know, some patients or some physicians may say a patient has grade 2 and other physicians may say a patient has grade 3 encephalopathy.
So I have a question for you, Vinay. So if the condition is called acute-on-chronic liver failure, shouldn't there have to be some, you know, just like with acute liver failure, some minimum degree of liver dysfunction to actually have the condition? Like, why shouldn't we say that you cannot have ACLF if your bili is less than 5, for example? Because to me, don't you lose face validity of a condition where 2 of the 4 letters a person doesn't have?
Sure. So when you consider, again, the Easel-Cliff definition, that quote unquote liver failure component was based on the development of decompensated cirrhosis. Now, that said, with your point, which is the fact that there may not be liver synthetic dysfunction, 2 points I do want to make with regards to that. So number one is that, again, the conclusions which have been drawn is that really it's ACLF grade 3 where you would consider increased priority. And now I know you brought up your slide, I think that was from Dr. Hernandez's study, which showed, I don't know how many, 40% or 60% have liver failure among patients with grade 3 ACLF, but keep in mind that bilirubin cutoff was 12. So there may be a good number of patients with ACLF grade 3 who actually have liver dysfunction, which I would consider a bilirubin above 3, which is kind of based on the criteria for which we decide not to consider TIPS placement or transarterial chemical embolization because of baseline synthetic dysfunction, unless the patient has an extrahepatic obstruction. So what you need to look at is again, the patients with the more severe grades of ACLF and what percentage of those patients have actually have liver synthetic dysfunction based on the bilirubin. But the second point is, again, the ACLF transplantation tier, which has now been adopted in the United Kingdom, they do incorporate that. So they do take that point into consideration, and they do say that the patient does have to have synthetic dysfunction as manifested by jaundice and coagulopathy. I don't know the exact cutoff numbers, but it's available online. But that is correct, though, that a patient who has a completely normal bilirubin but is in respiratory failure and septic from COVID pneumonia, that patient shouldn't be prioritized for transplant.
So I think one of the issues that's hanging here is that what we are really trying to do with our allocation is to save lives, but there has been limited attention paid to what happens after transplantation. And the kind of patient who spends the rest of their post-transplant life in and out of the hospital, in a skilled nursing facility, debilitated, is suffering from psychoactive complications of the immunosuppressive medications, all of these things which tend to go hand in hand with transplantation for people that are very frail or have ACLF3. I think there's this blind spot where we just haven't asked patients about what the kinds of outcomes we ought to be preserving. And I worry about whether transplantation in ACLF3 intubated patients and the like will advance the aims of patients. And I wonder if each of you could take this question. So David, you want to start with that?
I think it's a great question. I think, you know, one of my mentees at Penn, Tess Bitterman, one of her, you know, master's thesis was looking at sort of pre-transplant healthcare utilization and post-transplant healthcare utilization, and sort of look at ways to predict. You know, I think I agree with you. I think, you know, we tell people you can live 2 or 3 years. We don't tell them they're going to live bedbound or, you know, spend, you know, 2 years in a nursing home. I think that needs to be integrated into allocation, not just the quantity of the life, but the quality as well. And again, I think, you know, there have been studies that people that have more healthcare resource utilization. So you're in an ICU for 2 weeks, you're on a ventilator, you're going to have a lot more healthcare utilization afterwards. And is that what the patient wants? And I don't think it's unique to organ allocation, but I think it's a problem within all of healthcare.
Now, Vinay, you're actually the one who's generating the data on the real world experience of transplantation for these patients. So I wonder what your take on this question is.
Yeah, absolutely. It's very important. Now, we will present some of this data again at AASLD at one of the transplant sessions. But what we examined was resource utilization. It's not, we weren't able to examine quality of life, but you can extrapolate that spending X amount of time in the hospital poorly affects your quality of life. What we did find in some of our data was that when controlling for additional factors, including MELD sodium score, being in the ICU at the time of transplant, et cetera, a variety of factors, pre-transplant infection, that it was the grade of ACLF which correlated with length of post-transplant stay, length of post-transplant dialysis, as well as discharge to a rehabilitation facility. And these metrics are just not accounted for in the current system. And so I think that is something, whether we use ACLF-based priority or not, we should consider these metrics. And that is one of the concerns I did have, to play devil's advocate, that if we are going to blanketly prioritize everybody with grade 3 ACLF, then by nature, we are going to transplant more of those patients. That's just how it's going to work. And if we're going to do that without considering these post-transplant consequences with regards to resource utilization, then we could get ourselves in a concerning situation.
Thank you. And there was also a question from the audience emphasizing the need for the involvement in patients and how we ought to be adjudicating the outcomes on which we condition our allocation policy. So I think we have time for sort of final thoughts. I'll turn it over to David and then let Vinay get the last word.
So I thank you for this opportunity. Again, I think I'd argue this is an area that we need to study. I think this is nowhere near prime time. I think we need to better refine what is ACLF. Who do we think, if we're going to give it, would even get priority? But I think the bigger things, even if we get all of the data, is how to operationalize it. I think you can't, and I think this has been shown with the gaming of the system with liver ICUs and things like that. We can't have a system of priorities that has a subjective basis to it. So I don't think, beyond the data collection, the validity of UNOS, when brain failure or, HE grade is part of it, I don't think we could ever consider ACLF prioritization in the US until we actually could find an objective way to do it, because I think, unfortunately, people will game the system, and that is a major problem.
Vinay, take us home.
Sure. So yeah, I don't disagree with some of the points that were made. I will say this, I will say thank God for Europe. So Europe was way ahead of us when it came to transplantation for alcoholic hepatitis. And luckily they're ahead of us when it comes to prioritization for ACLF. And in particular, as I said, both Spain and the United Kingdom have implemented their policies. So I think the good news for us is that it is probably too early for prime time in the United States, in particular, considering that we don't even have a definition we all agree upon. So hopefully what we can see is that there is going to be some real world data over the next couple of years in Europe, and we can see how well that's worked. Was there really an improvement in mortality, and ultimately did that lead to survival benefit? And how did the patients do post-transplantation with regards to outcomes unrelated to survival? So the story has yet to be written.
Well, I thank you both, and I particularly like that message because we're very fortunate here to have had everybody attend. We have attendees from around the world, and we have a story that is being written, being authored by the two speakers that we had here today. So I'm very privileged that they spend their time with us, particularly Vinay at 4:30 in the morning. And I'm very thankful that everybody attended and participated. And I hope you look forward to the next installment of our debate series coming up in a couple of months. Thank you very much.
Thank you, Elliot.
Thank you.